What we presented on was risk factors for a special type of bone toxicity for patients who receive treatment for ALL. So acute lymphoblastic leukemia, which is the most common malignancy in childhood, has had exceptional cure rates in pediatrics. And so overall 5-year survival rates are greater than 95% for all comers. That's been accomplished through intensification of chemotherapy and very good risk stratification. And so some of the ways that we've intensified therapy over the last several years, including higher doses of glucocorticoids or steroids and higher doses of asparaginase. And so a key toxicity that has emerged out of the treatment with those two drugs has been the development of osteonecrosis, or AVN. And so what this is it's localized bony tissue death of the weight-bearing joints, especially the hips, knees, and ankles. And it occurs most commonly in older children, so children between the ages of 10 and 20, and a little bit less commonly in children between 1 and 10. But those children less than 10 are actually 75% of our overall population. So what we're trying to do is figure out why certain children get AVN and other children do not. And so what we did is we looked at a large population of patients treated for NCI, standard risk ALL, and the Children's Oncology Group, and then tried to verify our findings in a high-risk population. So the same age children, but now higher risk therapies. And what we did is we performed a genome-wide association study looking at all the variants in the genes across the genome and tried to identify ones that were associated with the development of osteonecrosis, or AVN. And so what we found were some interesting variants in a gene called BMP7, and then a gene that actually changes the protein, so a non-synonymous variant in a gene called GRID2. And so these variants, when they're present in patients, place them at dramatically higher risk of developing osteonecrosis than other patients who got identical therapy, were the same age, had these other similar risk factors, but who didn't develop osteonecrosis. And this is interesting for a couple of reasons. The biggest is that it probably tells us a lot about why osteonecrosis is happening. So it may not be these exact variants that are always the case in osteonecrosis. In fact, they explain a relatively small number of children who develop osteonecrosis. But variants in those similar pathways or variants in related genes may be present in other children. And in fact, what we did is we extended our findings to look at related genes through gene pathway analysis, and then look at specific tissues through enhancer enrichment analysis. And we found that other genes that were related to the formation of fat, which may be fat elsewhere in the body, may be fat in the bone, which we think does cause osteonecrosis. And other genes in glutamate receptor signaling, so this whole class of receptors that responds to glutamate, which is a chemical in the blood, and these whole class of receptors seem to be associated with the development of osteonecrosis. This is important for a couple of reasons. And so the first is that it tells us that the inside of the bones and the tissues that are there, the mesenchymal stem cells that make up the stroma, or the background tissue in the bones on which hematopoiesis and cancer lives, may be important for the development of osteonecrosis, because those cells can become either bone or they can become fat. And our variants may influence which of those two happens. The other thing that happens is that we learn and confirm our prior findings, which is that glutamate receptor signaling seems to be important for the development of osteonecrosis. And so this is probably true for two reasons. The first is that glutamate is directly toxic to the vasculature. And so that's seen in adults with stroke patients. They have higher levels of glutamate. But we know that our chemotherapy increases glutamate levels. Both the steroids themselves and then also the asparaginase we give causes an increase in plasma glutamate levels. So we may be influencing osteonecrosis risk through those ways. The other thing we learn is that the variants within these precursor cells within the bone marrow are probably important to the development of osteonecrosis. And so both of these things give us testable questions that we can take back to the laboratory and then try to answer new questions. So we have an animal model in mice that tries to evaluate osteonecrosis, and so we can test whether these changes in mice also increase the risk of osteonecrosis. If that's true, then we need to do a second series of tests and make sure that things that we do to try to reduce these risks don't also affect our ability to cure cancer. And so we want to make sure that whatever we do to decrease osteonecrosis, we don't also decrease our cure rates. And so we're in the process of doing those follow-up studies in the laboratory to try to kind of further the findings that we've found in the patients, take them back to the lab, figure out more details about what they mean, and then take them back to the patients so we can either predict who will have osteonecrosis and change their therapy, or modify therapies in ways that don't affect our cures but do allow us to affect osteonecrosis and decrease it.